them to come to the dais and take their seats. Dr. S.K. Farid Ahmed, surgical oncologist. Dr. Khalid Hamid, medical oncologist. Dr. Nadim Parvez, he's already here, he's clinical oncologist. Dr. Mohammad Ghulam Mustafa, Professor Ghulam Mustafa, Professor of Histopathology, the most precious one. Dr. Mohammad Afzal, medical oncologist. And last but not the least, Dr. Firdaus Shahriar Said, clinical oncologist. So I will be focusing on a real life case and some new recommendations and how to incorporate the recommendation in our clinical practice. Basically, the consensus to clinic, how should be the journey. So the case, a 21-year-old female diagnosis as carcinoma breast right. It's a very brief history. So histopathology report, IDCC grade 2, and ISC ER positive score 7, PR positive score 7, HER2 2+, and the FISH was negative. And KI 67, 25%. Clinical stage T3N1M0 after having all the MRI, CT scan, chest and abdomen, and all this. The stage was T3N1M0. And BRCA1-2 was negative for mutation. So I'm starting with Dr. Afzal. Are you okay with that? I think
Yeah.
youngest one. Okay, so what would be your treatment option for this patient? This is an operable LABC and luminal A.
So this is a grade 2 ER strong positive, PR positive, and it is HER2 negative. So clinically, she had T3N1 disease. I would start her with the neoadjuvant chemotherapy, and I would give her 4 cycles of anthracycline-based combination therapy, followed by weekly paclitaxel. And if she is young, then dosed as AC followed by dosed as paclitaxel.
So very much agreed with you. Even though the luminal A tumors are not that chemosensitive, and the PATCR is not that great, even though the patient received neoadjuvant chemotherapy as it was T3 tumor to facilitate the breast conservation surgery.
If it is, sorry to bother you. If she was post-menopausal, I would not incline towards give her chemotherapy. Yeah. But she is young. In either case,
and to facilitate BCS.
Yeah. So I will give chemo.
This is the first message. For luminal A breast cancer, we don't need neoadjuvant chemotherapy for all patients. The PATCR is not that great.
Yeah. So age should be considered.
Yeah. So the patient received NACT 4 cycles like your protocol. Then BCS with axillary clearance was done, and the histopathology report was YPT2N0. That is very expected, not PATCR. So we know the PATCR in luminal A breast cancer is at the tune of 10 to 18%. So this is quite expected that there is no PATCR. And the surgeon advised for ISC again, and now it comes as TNBC. So my first question to all the panelists, and it will be a rapid fire, just yes or no, okay? Very short time. So is it a routine practice for you for receptor retesting, yes or no?
Yes.
You retest the receptor after surgery for every patient?
Yes.
Okay, Dr. Afzal.
So I will not do the repeat testing. If initial test shows strong ER, PR positive, HER2 negative, no. If there isn't a discordance among the chemotherapy and the results, like if she is triple negative and there is no response, then I would suggest. If it is HER2 positive and I didn't get the response, then I would do, but not for the ER, PR. I know this is not a chemosensitive tumor.
So if there is suspicion, sir, I'm coming to you later on after getting their views. So for you. So yes, for every patient?
No.
Would,
anyway, this is the problem of medical oncology.
If there is any suspicion.
I'll take the end product, but I would not request the repeat.
Okay. So sir, for you, receptor retesting is a routine in your practice?
Not in my routine practice.
10 years, I am going back 10 years ago when I was doing my clinical fellowship. We had a big study done on this discordance of ER receptors pre or HER2 protein pre and post. So we came to know that is 10 years ago that there was a discordance in 2% of all the patients treated with new adjuvant chemotherapy and 0.7% patients who had HER2 positive disease previously had become HER2 negative or vice versa. This is not the standard guideline worldwide. It has been tried and tested several times. There are multiple studies, at least I know 15, 16 studies, which have shown that post neoadjuvant retesting of the receptors is not the routine thing, should be done. There is no guideline, at least I'm talking about the UK guidelines. We do the receptor testing pre-surgery and pre-chemotherapy. And then if there is any metastatic disease during the course of the treatment or after, then we will do the testing again, otherwise we will not.
Okay, Dr. Farid, now I think you are the boss in this scenario. Especially after operating, you usually send the specimen to the histopathologist with some advice. So what is your practice, sir?
Thank you. Depends where I was working. If I was in UK, it's done once and that's it. But in Bangladesh, I have learned my lessons with few scenarios. So when I see a patient, I've done a core biopsy, histology came out as HER2 positive. Now it comes to my mind whether it's an accurate report results. So I always like to do a double check from a different lab to confirm
when there is suspicion, but not for every patient.
For in Bangladesh, in Dhaka,
for every
my
patient.
practice is now, I always advise a repeat HER2 because I have seen quite a few
HER2.
cases. Yeah, that it's positive. Patient has got Herceptin, 3 shots, no responses, and I repeated the test elsewhere, came out as negative. So,
if no responses,
not
but-
after surgery.
But if
I would
response, if there is response, then also you do the HER2?
no,
No.
no.
Dr.
After
Sahida,
core biopsy, I do it twice. I advise patients, but after surgery, no, I don't routinely send any IC.
So, Dr. Farid's point is that it's not after chemotherapy. He's doing it before to confirm the test is correct or not. So that would not. So the question is that. So it means you're not
After
doing
surgery, after surgery, not a routine.
Not after surgery,
a-
routinely. No,
Sir,
I'm not
I
doing
would-
it.
yeah.
So finally, sir, I
okay.
would like to know your
Doc-
thought on that.
Doctor,
Regarding, I think I have got the answer of second and third as well from his comment, but I would like to know your comments regarding this.
Dr.
question.
Sahida, just one point before that. Just in concordance with Dr. Farid, yes, we get why I do all the tests, despite of the recommendation, England or whatever. We have in practical life seen many discordances. When we do the core biopsy, there are one thing, and you have given, it has shrunk. There was residual tumor, and then when we did it again, ISC, it came out not always, but many times, not the same thing. It's a tumor heterogeneity is there. It's you are taking just a core, and when you are and it is shrinking, but the thing that is remaining there, it was not maybe expected. So then it comes to the mind that there might be some changes. That was the rationale, or that is the rationale that I do it all the time, and many times I get the different result. According to that final result, my treatment follows.
So usually, a receptor discordance post-neoadjuvant was seen in HER2 positive disease. When you give an entire HER2 therapy, the receptor has gone down, and you may find HER2 negative. And in triple negative, when there is no receptor, and you may find something like hormone receptor positive. But usually in hormone receptor positive, there is no down regulation of the receptor or no discordance. That what I read from the material.
Sir, your valuable opinion and with the scientific explanation, because you are the
Actually-
right person, sir.
Actually, this situation, this type of scenario can happen. So first of all, as Dr. Said said, that tumor heterogeneity.
Heterogeneous.
So there are some areas which are negative. There are some areas in a tumor which are positive. So that is one issue. Second issue is obviously technical quality and the clone used by the lab and all these things, the technical issue. And the third issue, as Dr. Afzal was telling, that when you treat a ERPR positive patient with anti-hormone therapy, the sensitive tumor cells are gone. They are destroyed. So only the negative or insensitive clones, they remain there. So if you do a second ERPR test after
NSA.
chemotherapy, you will get negative. That is possible. And regarding HER2, the same thing. If you give anti-HER2
Can
therapy,
change.
the same thing can happen. And it is known that 15 to 20% cases, you will get a changed result, as he was telling that they did RCT. So 15 to 20% cases for ERPR, the result will change. And for HER2, about 10%. Total 10% of the total cases, the result may change. So these are the facts. So it is not wise to do all cases. It is not. Unless
Only
you have a
strong
new
suspicion.
disease, unless you have a new disease, a metastatic disease, and one, if in the pre-treatment it was negative, you can consider then as post-treatment to do, because if there is positive, you can treat that.
So I have got my answer, sir. So now the most challenging question for the clinician, which one we should consider now for further decision making? Because it is once hormone receptor positive, a 21 years old female, now TNBC, and the treatment is quite 180-degree different direction. So the change from positive to negative, if I give you a reference of Catherine trial, neoadjuvant chemotherapy plus dual anti-HER2 therapy, after, then surgery, if not PET CR, they give TDM1, no? Yes. So they analyze a subset of patient. There are the patient, they retest the receptor, and some patient, they are HER2 negative. Still, they continued the TDM1 to this patient, and they showed they got benefit. So from this trial, this is the recommendation. If the HER2 once positive but become negative, you have to offer the patient anti-HER2 therapy, even though it is negative. On this basis, if it is now negative, which one we should consider? It is as a hormone receptor positive or negative, Dr. Afzal?
So I would consider the aggressive biology. I would go for the treatment of aggressive biology. Triple negative is an aggressive cancer. She is a young patient. So I would give her the based on the CREATE-X trial, I would give her the capecitabine for 6 months. I would like to treat her as aggressive as possible.
As aggressive
Because
as possible.
now the receptors are negative. Must be there is a clonal evolution of some sort of a triple negative cancer. So I would like to treat the aggressive one, not the hormone receptor positive protocol.
But after the treating the aggressive one, like my second option, after giving capecitabine for 6 to 8 cycles, would you like to go for hormone therapy? Because any ER or PR, the guideline says offer the patient hormone therapy. Should we omit hormone therapy or deprive the patient from this benefit?
So now, now the receptors were negative. Would the hormonal therapy and the CDK4/6 work in this case? I'm not sure. I'm not sure.
So I would like to know your view on that.
Thank you very much. Yes, I agree with Dr. Afzal that we should be treating as a triple negative breast cancer. So because we have doubts now, so we need to revise and go back to the pathologist to get a second opinion, because there can be an heterogeneity, clonal evolution, all these things can happen, but we would like to have a second opinion. And in case if the second opinion is too consistent with the triple negative breast cancer, the patient will be considered and treated as a triple negative breast cancer and will be treated with capecitabine, not with the hormone treatment, unless there is a metastatic disease, and then we will repeat the biopsy again.
Would like to make any comment on that? You're clinical oncologist as well, no?
I agree, because now we have done the testing
Yes.
and we got the test result very different. And we have all this discussion, sometimes treatment can change that. But however, if with the triple negative is more aggressive, if we cover the more aggressive form, the other form will be, hopefully will be less, of the patient risk of recurrence. So I would go by I agree with both my medical oncologist colleague that I will go by the triple negative.
So you will stop after capecitabine, no hormone therapy or no ovarian function suppression for this patient.
I have to say, should we disregard lab errors? I mean, are we accepting that there is no chance of lab errors, right? Slide preparation, receptors might die. There are a lot of things. I mean, Professor Mustafa is here. But my question is, are we not considering that as a possibility? Or are we just accepting that TNBC is the one? Or would you like to retest it somewhere else, third time?
So,
Third time?
so whenever there is a dilemma, always we have to go back to the previous slides or go back to the previous history and let's review it. So what we do in our practice is whenever we counter these kinds of a dilemma, we go for the first slide or the first case and then rediscuss it, ask the pathologist to re-review the pathology specimen, check the receptors again, whether there is in the same receptor that was initially reported or now this time has been changed. So it's better to discuss this thing again with the pathologist to review both the slides, number one, before the treatment and after the treatment, to have a conclusive treatment protocol for the patient.
And I just say one last thing. I must have overheard something from you. Said, irrespective of ER or PR, if anyone is positive, hormone therapy should be given. But not to my knowledge. Well, I thought is estrogen receptor positivity dictates
Any
hormone
ER or
therapy.
PR. Yeah, any ER, even the score, if the score is 1+, we have to offer the patient hormone therapy. This is the guideline says.
NCCN guideline, they
NCCN
specifically
guideline.
mention on the footnote that
Footnote.
any degree of positivity is considered to be positive for the hormonal therapy.
Hormonal
You're
therapy.
saying progesterone receptor.
Yes, only
For the
for
ER.
Hang on. I know that. All I'm saying is, she mentioned either ER or PR. That's not my problem.
No, it's ER.
Exactly.
So what is
So
the
let's make it very
definition?
clear because the audience needs to know. In Bangladesh, I have seen many times PR positive, ER negative, PR positive patients been getting hormone supplements.
Actually,
This is my problem.
ER negative, PR positive, this can happen only 2% cases. And if you get ER negative, PR positive, it is a technical fault of the ER. So mind it, only 2% cases you can find this.
So,
But
may I add?
if PR is positive, ER must be positive.
So what is the definition of hormone receptor positive? According to NCCN guideline, any ER or PR. This is clearly written. Any ER or PR, you have to define this
So
patient.
Dr. Shahina, the
hormone
benefit
receptor.
was more in those patients
Yeah.
who are ER positive.
ER is more weighted, but the definition is like that. Any ER or PR is hormone receptor. Right, Dr. Any ER or PR. It should be defined.
I agree with the panel here. Yes, we focus on the ER positive disease
Yeah.
rather than the PR, and it is very, very rare to find someone with PR being positive or strongly positive and ER being negative. Obviously, we need to go back to the histopathologist and repeat the biopsy, revise the biopsy result. Okay, but it is very unlikely that we will or I will give anyone with PR positive hormone treatment. Hormone treatment on its own has got a good amount of toxicity. So I do not want to give any patient any hormone treatment who does not carry ER positive breast cancer.
So, Dr. Firdaus, you have something to add with this treatment protocol?
Yeah, the treatment protocol is as told by.
What do you offer the patient? The
Oh.
capecitabine 6 to 8
Yeah,
cycle and then
capecitabine.
stop there?
Yeah, capecitabine 6 to 8 cycle. I prefer 8 cycle if there is no tolerability issue up to 8 cycles.
Up to 8 cycle.
And then I'll keep the patient on follow up. And if there's no metastasis, I'll be, the close follow up is needed because it's came out as triple negative at the end. Right.
So there is another Chinese trial in which they used to give a metronomic dose of the capecitabine,
625 milligram per meter
625
square.
milligram per meter square twice daily. So that is also in adjuvant setting for patients who have residual disease. For patients who didn't receive neoadjuvant chemotherapy, this
Yeah,
is
that is
particularly for those.
Adjuvant patient
So,
as well. Yeah,
so
adjuvant.
you must discuss both the options with the patients, considering she is young. You don't want to put her on just observation. So you have two options. You can discuss with her with the capecitabine based on the CREATE-X trial. You can discuss with her with the Chinese trial, which has an 11% invasive disease-free survival benefit with 1 year of metronomic capecitabine.
1 year, 625 milligram continuously. But that was adjuvant trial. CREATE-X is new adjuvant trial. I think this is very much applicable for this case. Okay. So I think the decision is quite very uniform from all the clinical oncologists that we should treat the patient as TNBC and offer capecitabine for up to 8 cycle if tolerate, and if not, that 6 cycle we can stop. Yeah, BRC12 was negative. Otherwise, our life would be more happier. We can offer olaparib to this patient. That would cover the ERPR positive or TNBC both. If she were BRC12 mutated, that would be better for her, for us to offer olaparib to this patient.
So, if she's positive for the BRCA1 and BRCA2, would you consider
Olaparib.
direct olaparib, or you give the capecitabine then followed by the olaparib?
No, first, if BRC12 positive, I would like to go olaparib first. Yeah.
So, in
Olympia trial.
what I do in my practice, I used to give 6 to 8 cycle of capecitabine, considering these patients are young and high risk of recurrence. After completion of capecitabine, I used to put them on olaparib maintenance for next 2 years.
But you know, the CREATE-X trial, they didn't subclassify the patient according to BRC12.
So they basically don't look at that.
Look at that. But this Olympia trial is very much molecularly driven trial. So I think I will trust this trial more than
Both the options are
Yeah,
correct.
yeah.
Both
So
the options
what is
are
your
correct.
opinion regarding this? Olaparib only or capecitabine plus olaparib?
Yes, olaparib only. Olaparib has shown significant overall improvement in the overall survival as well as disease-free progression, and it is far superior response rate compared to the capecitabine. So yes, I will not give capecitabine. And I follow the guidelines for whatever is being given there. So we will just give the olaparib, and that's why in my talk as well I suggested that all the patients with triple negative breast cancer patients, they should have the genetic testing right at the start so that we can find what treatment we are going to offer to them.
I think I can end here. So now I have very time, like only 8 minutes. So very quick comments from Dr. Farid. Omission of sentinel lymph node biopsy. This is a St. Gallen recommendation, this 2025 consensus recommendation that for postmenopausal stage 1, positive, HER2 negative, grade 1 or 2 tumors with negative axillary ultrasonography, you can omit the sentinel lymph node. Is it practice changing for you? If not, what are your concerns and challenges? And there are some papers from ESCO publication as well regarding the pros and cons. So in very short 2 minutes.
Assuming if I've got a very good sonologist and radiologist and an excellent pathologist, I would definitely follow that. But current context, we are slightly a little bit, we have to be a little bit cautious about the ultrasound report is a big question mark. And even the other day, I had a PET CT scan saying normal axilla, and axilla was full of small, hard, positive nodes, at least 20 of them. So that doesn't mean that all PET CT reports are wrong. What I'm saying is, it's more common with ultrasound report in this part of the world. So I would be slightly cautious because clinically we may not be always getting, not positive or negative. If it's a chubby lady, it's very difficult. But then we rely on images. Yeah. And then if the image is not accurate, I have to be a little bit careful about that. But otherwise, I would definitely support that. And it would be case selective basis. If somebody 70 plus, or elderly lady 75 or above, and is good tumor biology, I would be happy to avoid, dissecting axilla.
Okay. So basically, you need a very good ultrasonography, that's radiologist, very good ultrasonography report, no? So this is the time for Dr. Nadim Pervez. So I'm very much into de-escalation. especially considering my limited resources and a long queue of 6 and 8 months for a patient. So based on there are recommendation from St. Gallen consensus based on NSABP B51 or RTOG 1304 trial that omission acceptable after PAT-CR in stage 1 and 2 cases. Sir, is it practice changing for you? And if not, what are your concerns?
Thank you very much for this
And you
question.
please consider our limitation as well.
Right. So thank you for this question. I was part of this study as a co-investigator. So I have some insight into it. And I talked to the PI very recently, I conducted actually for a webinar for him. And I got the final take from him because he was doing the quality check as well. So I would say partly practice changing and partly not. So the reason I would say that the trial was started, they were started only with the node negative patient. Then there was accrual issue. I was facing challenge as well, and like other co-investigators, to enroll patient. Then they expand the enrollment. So these things may not be published in the final paper. So we need to remember this limitation that accrual was an issue when in the beginning we come, and then they expanded, and I saw that by the time I left Canada, and I was not part of it. So anyway, then the results come. When I conducted the webinar of the PI, he did the quality checks, and I asked him, what is your take now? What you're doing in your practice? So he's saying all T1 patients, he is applying this finding, and not with T2, not positive with complete response. And I asked his question that why? So his answer was, this is Dr. Atif Khan, who's Aga Khan graduate, Dr. Nadeem Basi know him. He's in Memorial Sloan Catering nowadays as head of the department. So he said the reason is the trial duration is shorter.
5
And
years.
it's 5 year. We need to be careful about that. And plus, he said that when he was doing the quality check, if the results are not favoring according to overall study, was actually above T1 patient. So he said, hold tight. I'm not saying that cannot be completely applied later on because we need to have longer follow-up. But at this time point, he suggested to limit this application of this trial to T1 only and not to stage 2 like T2.
Yeah, but the St. Gallen, they recommended in stage 2 as well. This is the
Yes,
latest
based on the trial.
recommendation.
Based on
Yeah.
the trial.
And regarding this, that's the 5 years of data. With 5 years of fast forward data, we adopted this fast forward trial, ultra hypofractionation as well.
Which I did not adopt, to be honest.
You
because
adopt, but
yes,
some part of the world
I did.
adopted.
Yeah, no,
especially this is-
many people actually,
Yeah.
a vast majority adopted.
Yeah.
What I follow more that when we have this Florence study
Yeah.
data, which is 10-year data and partial breast irradiation, which is less toxicity, is better option than the fast forward. The other problem is the fast forward was for the shorter duration. But shorter duration, when you need to give the boost treatment, it is not shorter anymore. It is 10 days of treatment, so it means 2 weeks. If you go to 3 weeks and you apply SIB boost technique, which is RTOG 1005, I was co-investigator and know how well it was conducted, then hypo SIB trial, then this third one trial as well. So IMC, MC2 trial. So there's multiple trials. So either I go for APBI if patient is eligible. If not, then I go for SIB because the boost benefit will not be given to our patient.
Okay. So very quickly, sir, I have 2 minutes time. So the Supremo trial data, 10 years of follow-up now out.
Yes, but that was not for
1 to 3 lymph nodes or tumor T2 with some high risk factor like LVSI positive, grade 3 or younger patient, high risk group. So there is no difference in 10 years of follow-up, the RT group and no RT group. So the local regional recurrence, there's a reduction of 5% in node positive group, but not statistically significant improvement in DFS and OS. So how should we incorporate this in our practice, this trial data?
difficult because this was done at the time when neoadjuvant treatment was not considered. So this is for adjuvant. So we can extrapolate, but we cannot apply. And as I said that even this NSABP B51, I'm not saying that we will not adopt it, but it's early to adopt for T2. For this one also, I don't see this situation anymore now. But I know the PI of the study, you know, that he have good connection with him. And he's a very thorough investigator. I trust all the things what he done. The only problem is that our practices have changed a lot. So if you ask me, I am more into For the lymph node positive, there's another question, and
Yeah.
the different question of lymph node
Not
positive.
negative, but
Yes.
high risk factor.
Yes.
But if I'm not wrong, says there are some patient they got neoadjuvant therapy in that trial as well.
So the not so many. Like if you
Not
see
so
the
many, but
overall,
there's a number of patients
yeah,
got.
overall the
And-
application will not be able to come for neoadjuvant treatment.
And one of
in-
the criticism of this trial that time, the patient received suboptimal chemotherapy. But nowadays, our patient mostly receive anthracycline, cyclophosphamide, taxane. So I think this is more effective right now. The
Right.
chemotherapy will take care of local recurrence as well. So
Right.
we can adapt for this patient, especially node negative with high
can
risk
be.
of
So
recurrence.
just to bring one point in here, that the treatment to the lymph nodes were shown in any studies before. MA20, I was part of that
Yeah,
as well.
MA20.
All of them was for disease-free survival improvement. I'm not so much worried about when we are fighting for the lymph node treatment or no treatment. That's coming a little improvement. What my main concern is still, as you said, the fast forward trial, short follow up. Whether we do SIB boost or not do boost, and omitting the boost is more of a challenge. So to me, I did some presentation about that. What is our main target is actually the tumor bed plus some margin is the main target. If we are okay for that, we are okay for others. That's that's
So
my point.
I'm heading to the end. Thank you so much, my wonderful panelists. I could finish on time. So thank you so much for your insightful discussion and updating us.
Thank you again.